Good afternoon and welcome everyone to the webinar, COVID-19, Vax versus Fiction, Answering Questions and Presenting the Facts about COVID-19 Vaccines. I'm Carly Lovelet, the Director of Clinical and Rural Health Research for the St. Lawrence Health System, and today you're going to be hearing from Kylie Brogel, the Infectious Disease Physician Assistant at Canton Potsdam Hospital. This program was developed by St. Lawrence Health System Clinical and Rural Health Research Department in collaboration with the Patients Program at the University of Maryland, Baltimore School of Pharmacy, and a bunch of local and national stakeholders that have worked together to make this whole series possible. The educational series itself is funded through a Patient-Centered Outcomes Research Institute Eugene Washington Engagement Award. And although this webinar is specifically focused on COVID-19 and vaccinations, we're offering additional sessions where you can learn more about patient-centered research as well. So to check out recordings of past presentations or to learn about future presentations, I encourage you to visit the St. Lawrence Health System webpage. And Kylie Sands just put a link to that in the chat box for your reference. So before I hand it off to Kylie, I'd like to get to know who's joining us today. So you should see in just a second a poll pop up asking you to identify which group or which groups you identify with. So go ahead and fill that out quickly and click submit. We'll just give everyone a minute or so. This is great. It seems like we have a representative from at least one representative from all of the different groups, which has been one of my favorite things about offering these sessions, is just getting to see the people with different backgrounds and different experiences coming together, because we really are all in this together. And I truly believe that this webinar is going to be valuable to anyone with any background. I do see a few people are here joining us from outside of New York State, which is amazing. Welcome to you. I did want to just say that the vast majority of information in this presentation is going to be 100% applicable to you. However, Kylie is going to be speaking a little bit about the phases of COVID-19 vaccine distribution, and she's going to be specifically addressing the New York State guidelines. So for that section in particular, I would encourage you to consult your own state's resources to find out more about the phases in your specific state. It is my pleasure to welcome our presenter today, Kylie Brogel, Infectious Disease Physician Assistant. Kylie graduated from Clarkson University PA School and is part of the COVID-19 treatment team here at St. Lawrence Health System. She's also been essential to the vaccination rollout in our region to date, and she's here to cover a whole range of topics on the COVID-19 vaccines. So Kylie, take it away.
Thank you guys so much for having me. Thank you, Carly and the research team. I'm really excited to be here today to talk about something that's on all of our minds. So today's learning objectives, I'm hoping that after you attend this event, you'll understand some of the similarities and differences between the two EUA approved vaccines that are available right now, potential side effects of the vaccine and what you can anticipate, some facts versus fictions about COVID-19 vaccines in general, what herd immunity is and how we can get there and why that's so important, and a little bit about the vaccine distribution phases in New York State specifically, which can give you a little bit of a heads up on how to plan for the future. So why is this important? COVID is something that we have all been living with for almost a year now, which is kind of an incredible timeline to think about. And so where we're at now is only a reflection of this kind of current snapshot in time, but it's an important one. As of the 26th of January, 2021, we have 4,513 positive cases to date. It's a 6.2% positive results, averaging 69 cases per day over the last 7 days with 64 deaths. This is putting St. Lawrence County in one of the high risk or extremely high risk counties in the state of New York for number of positive cases per capita. Though our total numbers are typically lower than urban areas or more highly populated areas, per our population, these numbers are extraordinarily high. And one of the main ways that we can improve this and begin to see a downtrend in our number of cases is vaccination. So Pfizer and Moderna are the two vaccines right now that are EUA approved for use in the community. They're the only two approved right now. However, there are several in the pipeline. And not every vaccine is perfect for every person. So it's good to have a wide variety of effective vaccines coming to market, which is really great. So today we'll be primarily talking about Pfizer and Moderna. They are the mRNA vaccines. And so both of these vaccines use new technology utilizing mRNA. And I'd like to highlight that the term technology is used frequently when talking about these vaccines, and it really just means the method in which the vaccine works. It's not referring to electronics or microchips or really anything that we may commonly use the word technology for. This just means innovation of a new way to make a vaccine that has actually proven to be incredibly effective. So keep in mind that term messenger RNA or mRNA. We'll talk a little bit about how it works down the road. Other similarities between these two vaccines are that most side effects were minor and injection site related. Redness, soreness for a couple days, maybe some swelling. Serious adverse events between the two really just reflected the general population illness, which means the number of cases of severe events were the same as if they weren't doing a vaccine study. So some information to know. We hear things called serious adverse events versus side effects. What does that mean and how is it important to us? So if you're familiar with the data or you're looking through some of the primary literature or the research information sheets, serious adverse events are those that, as I said, are serious. They could result in death or are life-threatening, may require hospitalization, could require lead to a persistent disability or incapacity, and also including those that could have some vertical transmission from a mother to a child. Adverse events is a more general category, and sometimes people use the word side effects. And sometimes I feel that's a better word to use because not all adverse events are something that should really preclude us from getting a vaccine. So it's really anything that happens after getting a vaccine that wouldn't have happened if you didn't get the vaccine. Maybe headaches, nausea, maybe a change in some of your lab results should you have gotten labs shortly after that. But it doesn't necessarily mean the vaccine did something bad to you that's going to last in a permanent or even a long-standing way. So Pfizer versus Moderna differences. I'm going to start out with this slide that when I talk about the mRNA vaccines, Pfizer and Moderna, I classify them as functionally the same. People ask me all the time, which would you prefer, Pfizer or Moderna? And my answer is both. I think that they're functionally the same, and look at what the differences are. Pfizer had a 95% efficacy after their second dose. Moderna had a 94.1. That's less than 1% difference in efficacy, which to me is functionally the same. Pfizer looked at 7 days post-vaccination for their peak efficacy. Moderna looked at 2 weeks. Again, 1 week difference between when we may feel confident that we have the most antibodies. This is really not all that different. Pfizer did look at individuals who were 16 years and older. So Pfizer is approved for 16 and older, where Moderna is only approved for individuals 18 and older. Again, not that Moderna thinks something bad would happen to a 16-year-old who got vaccine. It just wasn't included in their study. And if we don't have data to support it, it's not something that we can go and put it to market for. And probably the primary difference between the two is that Pfizer is given at a 21-day apart between dose 1 and dose 2, and Moderna is given 28 days apart. And that's important to remember because that's a fairly strict rule. What we know about these vaccines is Pfizer was studied 21 days apart between their doses, which means all of that information we have is relative to getting 2 doses 21 days apart. And the same thing for Moderna, respectively, 28 days apart. So the importance of those dose dates is really significant because it's how we know we're going to likely get all of our community members to those peak efficacy rates safely. Vaccines in general are our drug, our medication, and they all come with their own risks. And so we want to be doing this in a way that's safe. And so following manufacturers' guidelines is always our best bet. And so that's what our current approach is. Both of these vaccines were also granted EUA or emergency use authorization from the FDA. We'll talk a little bit about what that means and how it might have given these vaccines maybe a little bit of a bad name unnecessarily. So what does EUA mean? EUA is an emergency use authorization that's given by the FDA, Food and Drug Administration. And it helps strengthen the nation's public health protections against chemical, biological, radiological, nuclear, and emerging infectious disease threats by facilitating the ability and use of medical countermeasures needed during public health emergencies. So this is a standard that was set well before this pandemic and is not limited to infectious diseases. EUA is, as it says, in an emergency situation, this is going to change the parameters that the FDA will approve something, and it has to meet certain strict standards. It's not something that just means we forego all the rules and we do what we'd want. It still meets significant guidelines, but it's used in certain scenarios where not approving something would have greater harm or greater risk to a population than moving forward with the drug, the intervention, or diagnostic tools. So criteria for FDA emergency use. So this is for anything that is going to bring to the FDA table something for approval. So the criteria are, when you're doing a research study, it has to have a minimum number of 3,000 participants. It needs to include large-scale efficacy and safety data. You may have heard this termed as phase 2 and phase 3 research data. A minimum average of safety follow-up for 2 months, and you need to enroll diverse subgroups reflecting your population's demographic. We need to know that all of our community members and individuals in the population are being reflected, so safety can be seen across all demographics. We'll talk a little bit later about how the Pfizer and Moderna data meets and exceeds all of these emergency use criteria. I really think it's important to talk about it as much and as often as possible, because I think the bad rap that some of these vaccines got was it was too soon, too fast. How could we have enough data to support this? So both Pfizer and Moderna enrolled greater than 30,000 participants. That's 10,000 more, or tenfold more than what was needed. And they met all of these criteria because they were granted emergency use authorization. They also are continuing their studies to go for a formal full FDA approval when they meet those data criteria as well. The way that these studies were able to meet this criteria comes down to a few things. One, there was wholesale involvement by the government, by private agencies, by the manufacturing companies to put money in to make as many novel ideas for vaccine as possible. That's always a hindrance when making vaccines in general. It's not having enough money, because many vaccines don't actually come to market because the idea was great and it didn't pan out in the laboratory. For the COVID-19 vaccines, money and funds were available to pursue many different types of vaccines to potentially come to market. And the second milestone that usually can deter vaccines being eligible for EUA or for full FDA approval is how many cases are available to test your vaccine against. If the incidence of your infection or what you're trying to protect against becomes so low, your study would be unable to say, was it the vaccine that protected me, or was it the fact that it really wasn't very prevalent anymore? And unfortunately, COVID has continued to rise across the country in different hotspots and different sites. So the cases were available to test the vaccine against. So there's really great data that was brought to the FDA for this emergency use that exceeded all of the minimums. So I really don't feel personally, clinically, that either Pfizer or Moderna was cutting corners or too fast to come to get approval. When talking about Pfizer and Moderna, just about everything is the same. So common side effects, particularly after the first dose, are pain at the injection site, redness, swelling, achiness, tiredness, a little bit of general malaise. That was most commonly seen after the first dose. The second dose for both Pfizer and Moderna is the exact same concentration and volume. And so what your body's doing it's already built itself an adequate or a large amount of antibodies after the first dose, and then we're giving it more. And when it comes to infectious diseases, it's usually not the bacteria or the virus that makes you feel unwell. It's your body trying to protect itself that gives you the fever, that gives you the aches and pains. And so what vaccine does for our body is tells us to ramp up those productions, which also tells our body to kind of feel a little bit unwell. It's working really hard to make all those antibodies to protect us in the future. And so after the second dose, it builds a really ramped up immune response, which is the overall goal. And it is common to have a little bit more severity of side effects in that the tiredness is a little bit more. Fatigue, body aches, fever or chills is quite common after the second dose and is more prevalent in the younger age population. So individuals under 50 saw higher rates of fever, chills, body aches, and some GI symptoms than those in the over 50 age group. So not uncommon. All were self-resolving, typically within 24 to 48 hours. But it's something to consider when you are scheduling your vaccine on your dose 1, that you're prepared for day 21 or day 28 to be ready for your second dose, and day 22 and day 29 maybe to be able to take it a little easy. So facts versus fiction. So I got to talk about this a little bit just a few slides ago, answering the question, were these vaccines rushed? And again, I really don't believe that to be true. And I believe that they did these really robust studies, both phase 2 and phase 3, that are continuing, which is really exciting to see the data continue, and it continues to be consistent. I think something else that was great to see is that Pfizer and Moderna really started most of their studies at similar timeframes, and they released data kind of in a similar chronology. And their data was similar, which is great to hear because they're using the same or similar technology in that mRNA, and we would hope to see similar outcomes. And watching 2 studies done in tandem gave me a lot more security that this wasn't just a fluke. One of these manufacturers didn't just get lucky. They had the same practices, they practiced them parallel, independently of each other, and they got very similar efficacy, very similar side effects, very minimal severe adverse reactions reflective of general illness, and no deaths that were directly linked to vaccine. So that's really encouraging. So not only do we have one set of research studies looking at this, we have 2. And it just further kind of confirms with me how well these studies were done. And the FDA for EUA use wouldn't consider a vaccine at this time unless they intended to bring it to full FDA approval, which means continued study. So it means that these companies were invested in making really good vaccine and to continue to put money and time and energy to support that. So as I said before, both vaccines had trials with greater than 30,000 volunteers, which is an incredibly large number that was recruited quickly, 10 times the amount required. And greater than 15,000 of those patients who received active Pfizer, only 8 reported cases of COVID after their second dose, and only 1 severe case, compared to 162 and 11 in the placebo arm. And the FDA evaluates and analyzes the safety and effectiveness of data through clinical trials in tens of thousands of study participants, and that helps inform the medical researchers on how to continue to improve. The other really important piece to note is that though we're calling this a novel mechanism in mRNA, this is not the first vaccine, or neither Pfizer or Moderna the first vaccine that mRNA was attempted in. Right now, there are still clinical trials ongoing for Zika and Ebola, and their hurdles are right now, there are not a high enough incidence of Zika cases or Ebola cases in the areas these studies are being performed to be able to prove that efficacy. So they weren't stopped because mRNA doesn't work. They are just still in a holding pattern or a slow progress because the cases aren't available. So it's really exciting that mRNA now has 2 vaccines proving the model of thought that this technology works. So I think we'll be seeing a lot more mRNA vaccines for other illnesses, which is exciting, and what is a silver lining that can come out of things like pandemics, where everyone is focused together on a goal of improvement, and we have opportunity for innovation safely and effectively with kind of all hands on deck. So other concerns of this being the first time this has ever been seen or done before is also just not true, but we don't see a lot of the information coming out in the media about Zika or Ebola because it's also not particularly relevant in the United States. So it's out there. The safety has been kind of proven in several research studies. So this was a really good model, and it's exciting that it worked as well as it did. Some more facts versus fiction. mRNA vaccine will change my DNA. In short, it will not. And why it won't is the way that this mechanism of vaccine works is pretty incredible. It doesn't require any SARS-CoV-2 viral particle components. No virus was used in the making of this vaccine. No virus is needed as a viral vector. There is no SARS-CoV-2 within the Pfizer and Moderna vaccines. What is used is a synthesized series of proteins called mRNA. It's a messenger RNA, which are types of proteins that do build genetic code, but it also is RNA proteins are used all the time for us to have these building blocks for all of our natural cells. So I think about mRNA like a recipe. What we're doing with this vaccine is we put a recipe within the vaccine and puts it within our bodies. Our bodies recognize that recipe like any other recipe that we're doing to build skin cells and hair cells and liver cells. This specific recipe is to create just the protein on the outside of the virus. So at the top of the infographic, you have the circle virus with the red spikes on top. Those are reflective or a picture version of what's called the spike protein. The spike protein on the SARS-CoV-2 virus is like a thumbprint. It's very unique to this virus. And so the antibodies that we make against those spike proteins are very unique to help protect largely against SARS-CoV-2 and in theory only against SARS-CoV-2. In the future, we may see they have benefit for other viruses, but the whole goal is that our body makes specific immune cells targeted exactly towards SARS-CoV-2 and particularly something that makes it unique. So that protein on the outside, the red spike protein, is a unique protein to this virus that we're targeting. So the recipe that's in the vaccine comes within your body and it goes through all of its reading processes to create just those proteins. Those proteins are what make us sick. It's not a live virus. It's only one small piece of it, but it's a small enough piece that your body recognizes it as foreign and builds those very specific protector immune cells against that protein. And those protector immune cells will work towards virus if your body should come in contact to it, because it will see that thumbprint protein on a virus that comes into your system and will be locked and loaded to go ahead and start protecting you and neutralize those viral particles. So what's being put in the mRNA actually doesn't have anything to do with the virus itself. It's a recipe for your body to use its own cells and its own pathways to make your protective immune system cells and antibodies. So that's really incredible. And I like to say it's a downstream effect. Your body doesn't have to do a whole lot of work to recognize something foreign, recognize a Trojan horse. This works right before your body's ready to make those antibodies, which is something it's really good at doing. We do it all day, every day to any kind of foreign agent that we may come across, other viruses, bacterial infections. So it's something that we were ready to do using our own cells. This is why it makes it particularly safe or reassuring for pregnant women, because you're using your own cells to protect yourself and protect your baby. There are no preservatives in this vaccine on Pfizer nor Moderna, which is why it needs to be handled and stored very cold, and it has a short shelf life. So there's no preservative that's left over for the body to metabolize. They're all organic products in the vaccine itself, which is great to, if we're concerned about kind of how clean a vaccine is. I don't love using that word, but these have very few ingredients, and most of them are elemental salts and that synthetic mRNA molecule. And DNA is safely protected within the nucleus of our cells. It's kind of in this Fort Knox. And what happens with this virus is the recipe gets put into our cytoplasm, which is well outside of Fort Knox. It never gets within the nucleus because it wouldn't know what to do. It's not read within the nucleus. It has all of its protein and structures done outside of that protective nucleus. So your DNA is fully and completely protected, and there would be no way for those to combine. They wouldn't speak to each other because that recipe doesn't read for proteins that would correlate with something to go into your DNA, into your chromosomes within your nucleus. So there is absolutely no way that this vaccine with this technology can affect our DNA. We talked about this a little bit early on. I think some of it is a bit of a bad rap where we're using the word technology to mean innovation and not how we commonly think about it for electronics and computers and things of that nature. There is nothing within the vaccine that uses anything of that nature. There's no way to be tracked. There's no way that would sustain. It also wouldn't live in your cells very long. Our cells turn over and they die and they disintegrate. So that microchip kind of wouldn't last, but it doesn't matter because it's not in the vaccine to begin with. So here's a complete list of the components of the vaccine. It's quite short. One of the ingredients in both Pfizer and Moderna is something called polyethylene glycol, which is a simple molecule commonly in Miralax or laxatives. Common ingredient in other medications that are safe for both those who are pregnant, breastfeeding, and all other individuals. Very low levels of hypersensitivity reactions, which is why there's very limited reason or contraindication to getting vaccine when it comes to hypersensitivity. Those are the only compound that I'm aware of is called polyethylene glycol and polysorbates. They're very similar. If you have anaphylaxis to those medications, that would be a contraindication to these particular vaccines. The ones that are coming up in the pipeline may not use polyethylene glycol, which is why it's important to have a diverse variety of vaccine that's safe for everyone. Pfizer and Moderna, because they don't use any live virus, makes it a very widely safe vaccine for many medical conditions, the immunocompromised. We're not doing viral vector vaccine for Pfizer and Moderna. So you're not asking somebody whose immune system is already compromised to help fight off whatever vector you're putting within. It's not live attenuated virus where your body does have to protect yourself to some degree. There is no viral particles. So that's a really great aspect to these mRNA vaccines that make them safe for almost everyone. So as you see in our short ingredients list, no microchips included. Herd immunity. I don't need to get vaccinated because herd immunity will protect me. Herd immunity is a really great thing. However, it's hard to achieve. And it's something that requires everyone to be involved to get to that herd immunity. So the idea of herd immunity is that a virus needs a host to live in. And if it doesn't have a host, which is our body and our cells, it will ultimately die off. And the way that we make ourselves inhospitable and a host that the virus can't survive in is by giving ourselves antibodies. And for some, that's through natural infection, and your body will have naturally made antibodies. And for some, that's going to be through vaccination. When you have those antibodies, it doesn't allow the virus to be within your system long enough to replicate. And that's how infection spreads. To get there, that means 70 to 90% of the population who's at risk of getting COVID, which is everyone could potentially become infected, would need to have immunity at either naturally or through vaccine. And as we know, natural immunity has been shown to wane over time. So we only feel confident that those who had COVID naturally have antibodies for somewhere between 2 to 3 months consistently. Many people even lose their immunity even earlier than that. The vaccine-based immunity is log scales bigger. Thousands and millions of more antibodies are produced via the vaccine than by natural immunity, and they last longer. So immunization is also important for those who have already had COVID because it's going to give you even more protective antibodies that will last you a longer time. So herd immunity protection, which is what you're seeing on the bottom picture to the right side, is when there's not enough hosts to hold on to the virus to allow it to spread. And it's going to take time because we have to remember that just because our neighbor is getting vaccinated doesn't mean enough people will get to herd immunity where we feel we don't need to. And herd immunity is intended to help protect those who can't get vaccine, somebody who it's unsafe to get vaccine, whether it's for COVID or for any other condition. And right now, we don't have natural or vaccine protection for children. So even though they can continue to get COVID infections and can spread them, we need to protect our children and those who are unsafe to get vaccine by getting vaccine ourselves. That's how to reach 70 to 90% immunity is going to be far more than 90% of our adult population getting vaccinated, because right now children just can't get vaccinated. So we need to think about that. It's not just 70 to 90% of adults or 70 to 90% of those who are at high risk. For herd immunity to work, it really means we all need to come together and think about how vaccine is important for us as a single individual, not acquiring COVID-19, but how it ultimately makes us protect others, particularly those who don't have the luxury of getting vaccinated. Vaccines are incredible kind of innovation in medicine, and they work twofold. They work at the level of the individual, and it offers us some degree of protection. And when we say things like 94.1% efficacy or 95% efficacy, that actually speaks to how it works for the whole population and isn't relative to just one person. So when we reach those 95% efficacy numbers and 94.1, it's when our whole population is well vaccinated. And that's going to be something we talk about a little bit more, where we need to continue with good social distancing, hand hygiene to help protect ourselves, our families, and those who can't get vaccinated. So though herd immunity is important, it's going to take us a significant amount of time to get there, but that doesn't mean we should stop trying. So if somebody who's listening here may be on the fence about, maybe you feel safe that if you got COVID, it really wouldn't be all that big of a deal, but every vaccine we give to somebody helps protect the next person. And so if that's something, if you have a family member who is immunocompromised, or a child, or a loved one who can't get vaccine, when you get vaccinated, you ultimately protect them that much more. And I'd like to talk about, this is specific to New York State, and it's the phased approach for vaccine distribution. So at the level of the state, a decision needed to be made. Who's going to get this, and when are they going to get this? And this was doing risk stratification and starting with our highest risk individuals and continuing to roll out to those who may be at lower risk for severe disease. It's not even lower risk for acquisition. It's also looking at those who may have some level of protection, or should they get COVID, have a low likelihood of becoming severely ill. So phase 1A is where we began, and that was in mid-December. Phase 1A was healthcare workers, residents and staff of nursing homes and other congregate living facilities, emergency medical workers, coroners, medical examiners, some funeral workers, those who work in or volunteer in vaccination sites, and all staff who have direct patient care, or we say patient facing. So that could be non-healthcare workers in healthcare offices. New York State is currently in 1B. 1B is individuals 65 and older. This is by far our largest group, and which makes 1B a very large group in general. It continues to include first responders, support staff for first responders who are working in municipal offices, firefighters and their administrative workers, police officers, correction officers, those who are doing in-person teaching. So public schools or college level in-person teaching, community-facing grocery store workers, so those who are out on the floor and cashiers, daycare settings, or those who are childcare, public transit, and those who struggle with homelessness and those who work in those facilities. This phased approach is dynamic and will continue to have positions added to it. And that's at the level of the vaccine sites to maintain, and then it's communicated to the community at large. So if you believe that you fall into one of these categories in phase 1A or 1B, I recommend that you go to the site, Am I Eligible New York State Vaccination? It's something easily Googleable, and it'll ask you a series of questions to see, are you eligible to get vaccine? And if you are, you can go ahead and schedule your appointment right from there. And if you're not quite eligible, it will let you know that you don't meet the current criteria, but that doesn't mean that may not change in a week or 2 weeks. So it's a website that you can constantly be referring to check your eligibility status. And so what we want people to do is be as informed as they can be about when they can get vaccines. So I highly recommend frequenting that website. Am I eligible in New York State COVID-19 vaccine? To keep checking in on your eligibility status. How to prepare to receive my first dose. This is kind of a complex question or idea. There are some absolutes in that I like for everyone to know, and then there's other things that are really good to think about. So really important to ensure that you've not had any other vaccine in the last 14 days prior to receiving your dose. So vaccines are those things that our body needs to make an immune response to. Shingles vaccine, pneumonia vaccine, flu vaccine, meningitis vaccine for some of our younger individuals. This does not mean injections like steroid injections, pain injections, medications that require injection use. Those are not vaccines, and you're eligible to take them at the discussion you have with your provider if this is a good time to continue to do that. But it's not a safety contraindication to receive injections within 14 days of your vaccine, just no other vaccine itself. Because what we want to do is we want everyone's body to have a nice clean slate and have one job, which is make as many COVID antibodies as possible. When we give multiple vaccines at one time, the body's kind of tasked to make several different types of antibodies, which for many other vaccine is safe and appropriate. But currently in a pandemic, when we want everyone to have the best chance to have peak efficacy, we want to separate out vaccines with a 14-day time in between. So for those who are receiving Pfizer, that really means pushing any vaccine to 2 weeks after your second dose. If you get them in between your doses, that's going to put you within 14 days when you get your second dose, or getting it 14 days prior to your first dose. For Moderna, there's pretty much a 1-day window in the middle where you could get vaccinated. I don't recommend that. It would be difficult to schedule it that way. Again, I would recommend 2 weeks before your first dose of Moderna or 2 weeks after your second dose. Other important thing, if you are feeling feverish or unwell, vaccine should be postponed. That's two reasons. One, COVID is still so highly prevalent right now. It's important not to give vaccine if you're COVID positive and acutely unwell. Your body's already working on making some antibodies itself. But also it's just difficult on the body if you have an acute infection or acutely unwell with fever. Your body's already working on trying to protect yourself from something else. And so the best thing to do is wait until you're fever-free for 72 hours. I highly recommend anybody with febrile illness get COVID tested at any of the local testing sites just to ensure that it's not COVID. When it comes to a COVID diagnosis, right now, there is no minimum time between a COVID diagnosis and when it's safe to get vaccine. You just have to be outside of your isolation window by the guidance of public health. There are some general guidances that talk about a 90-day wait before getting vaccine. That's not a safety wait. That's more your body likely has some level of protection. And if there's vaccine shortage, we want to make sure people who have no protection are given protection in a prioritized manner. But it's not a safety problem. And right now, it's not a precluding factor for getting vaccine. So I still recommend going to the Am I Eligible site, even if you recently had COVID, and check your eligibility status through that website. It's the most accurate way to know if you're eligible. The 3-month recovery is, again, not so much safety, but for having everyone to get equal opportunity to have some level of protection. Also, simple things, make sure you're wearing a t-shirt or something where your upper arm is exposed. This is an IM vaccine, and make sure your arm is easily accessible. So I'd say dress in layers to stay warm, but make sure that our vaccinators can get to your arm. There is a 15-minute or 30-minute, depending on your health history and your history to allergic reactions, observation period after vaccine. So I would give yourself a whole hour dedicated to getting your vaccine, and you'll likely be out far before that time frame but I would give yourself that time. All places that are offering vaccination have qualified medical staff to ensure safety during observation. They have appropriate medication should you have any response to a hypersensitivity reaction to the vaccine. And you're in a room full of healthcare workers, so it's a very safe environment to get vaccine. So some frequently asked questions. Does the vaccine contain SARS-CoV-2? Again, absolutely not. Not anything that's related to the virus itself. Those recipes are synthetically made with the appropriate proteins, so your body knows exactly how to build those antibodies. These vaccines specifically do not contain any SARS-CoV-2. Others in the pipeline may use some version of the virus to help prompt an immune response. That doesn't make those vaccines bad. It's just a different mechanism. These two do not use any viral components, again, which makes it more safe for those individuals who are pregnant, breastfeeding, or thinking about becoming. So because there's no virus in the vaccine, you cannot get COVID from the vaccine. Will I test positive for COVID-19 after receiving the vaccine? So twofold question. No, because there's no viral particles in the vaccine. So the nasal swabs or an oral pharyngeal swab or some of the saliva samples, those are looking for genetic sequence of the virus itself. And because the vaccine does not contain any viral particles or genetic sequences of the virus, you will not test positive through a PCR test. However, if you were to have a blood test done or donate blood where they are going to screen for antibodies, you may test positive, and you should test positive once you reach a peak efficacy. However, my general recommendation clinically is that we don't need to prove that our bodies have the antibodies by getting blood tests done after the vaccine, because the commercial antibody tests that are offered through laboratories that we use at the non-research level aren't looking specifically for that spike protein antibody. It's looking for an array of antibodies and just doing a total count. So overall, we would anticipate people to be antibody positive from the blood test. However, it's not necessary to go and get a blood test after getting your vaccine to prove that you have those antibodies, because the lab and the machines are not calibrated specifically for those antibodies. That's been part of the research that Pfizer and Moderna does to look at those titers and how long that they're being maintained in our bodies. They have lab equipment specifically calibrated to look for just that target antibody. So they're doing that for us. But for the swab testing, looking for acute infection, no, you will not test positive because of vaccine. If you are testing positive, that would be a reflection of a true presence of viral particles in your nasopharynx, which could be reflective of an acute infection, or possibly may reflect a recent infection that you've already recovered from. Who should not receive the vaccine? This is a really important question to talk about because these are the people we need to protect. So if you've had an allergic, a severe allergic reaction to a first dose of either Pfizer or Moderna, which would be something that would require epinephrine, defined as anaphylaxis, so difficulty breathing, that would be a contraindication to getting a second dose without further discussion with an allergist immunologist, or potentially having it done in a specific, very safe environment. So our guidance is, if you've gotten a first dose and you had a reaction that included the need for epinephrine, going to the hospital, that be discussed with an allergist or immunologist, and it may not be appropriate to do a second dose. It still should confer roughly 50% efficacy after your first dose, which is great, but you would also be somebody who hopes that herd immunity, that we reach herd immunity in our population to help better protect you. Other reasons that individuals may not be a good candidate for these two vaccines alone is the PEG, polyethylene glycol, or polysorbate allergy. Again, we're talking about severe allergies that either required emergency room visits and epinephrine for anaphylaxis, hospitalization, things that are beyond side effects from those medications. So if you get GI upset with those medications, that would not be a reason to not be able to get vaccine. If you have any question, primary cares are available, and I would urge you to reach out to your primary care or a specialist to discuss if you have any concerns if you should be getting the vaccine. A group of people that may not otherwise be able to get other vaccines would be the immunocompromised based on the type of vaccines that they are. There's right now no medical condition that would preclude you from getting the mRNA vaccines. So no level of immunocompromise is too dangerous to get vaccine. However, you may be on medications that might make the vaccine a little bit less effective. That's something you should talk about with the provider who prescribes you a medication that could be immunocompromising. The major medications right now that would or could inhibit some of your ability to make these antibodies would be certain active chemotherapy medications, certain T cell or B cell inhibitors, high dose methotrexate, or high dose chronic steroid use. If you think that those are medications you're taking, I recommend you reach out to that provider and discuss the risks and benefits of continuing those medications and when vaccine would be most appropriate for you. Again, it's not a contraindication on safety between those medications and the vaccine. It just may mean that if you're on those medications, your response to the vaccine might be a little bit diminished compared to somebody not on those medications. It doesn't mean it would be zero, and it likely would still be quite high, and any protection right now for me is better than no protection at all. So reach out if you think you're on a medication that may cause you to have a decreased efficacy, and your provider can help you make that decision. Do I still need to wear a mask after I've been vaccinated? It's really important to continue to do these practices because vaccines' intention are to reduce acquisition. So by having a vaccine, I'm protected and I have a low likelihood of becoming ill from the virus. It doesn't mean I'm not exposed to it. It doesn't mean it may not hang out in my nose or throat. And if it's hanging out in my nose or throat, I may be able to aerosolize that and give it to somebody else. But I may not feel unwell because I have enough antibodies working in my favor to protect me before I feel those symptoms. That's why masking and social distancing and hand hygiene are incredibly important, particularly because one, we're not at herd immunity, and two, the research studies are still looking at, is this vaccine going to help reduce transmission from one person to another? Until we have that herd immunity where there's not enough bodies to host the vaccine, we really need to continue with mask wearing because again, you may have protection for yourself, but we need to be thinking about how what we do affects others. And so wearing that mask is going to protect any of your aerosols or your droplets from being transmitted to somebody else when you may not know you have the virus in your secretions. I've tried to talk about pregnancy and breastfeeding throughout this talk because I think it's important and it's a big question that I understand completely. So right now, it's controversial in that there's not a ton of data available. So the more data, the more safe we would feel about this. However, all of the major obstetric and gynecologic societies have said really it comes down to the individual who's pregnant or breastfeeding, their level of comfort with getting the vaccine. There is no specific data in either set of studies that proves that it's unsafe. However, there's not enough data to prove that it is always safe. So the question really comes down to, is your risk of getting COVID more dangerous than your risk of the vaccine? So overall, the general guidance that I'm hearing from OBGYNs is by and large, get the vaccine if you're not otherwise having a high-risk pregnancy. Each pregnancy is different, and I would recommend reaching out to your OBGYN. And where you're at in your pregnancy also is another component of when vaccine may be your best idea. For those who are breastfeeding, there are no preservatives in the vaccine, and there's no viral components that would be transferred to the baby. And it's unknown how much, if any, antibodies would be transferred, but those would be antibodies you made yourself with your own cells that would be safe for your baby. And again, if you'd like to become pregnant, there was actually some data included in some of the studies for individuals who were not pregnant at the onset, became pregnant during the study, and they were continued throughout the study. And that's the data that's being used to make these decisions and inform decisions about getting vaccinated. There was no specific harm seen outside or risk of miscarriage or risk of adverse complications during pregnancy that exceeded the regular statistical probability of something happening during pregnancy. There's also no documented concern for decreased fertility in the future, as there's the primary concerns for long-term vaccine complications are typically not the vaccine themselves, but any component of it that may linger in the system for long-term. Again, the components of this vaccine were that very short list of organic salts, the mRNA molecules, which our body's very familiar with, cholesterol, sucrose, and polyethylene glycol, which is something that we all, probably have taken before in one form or another. So there's very limited concern about having long-term vaccine effects in the future, because not very much of the vaccine is going to hang around in your system outside of what your body's producing on its own. So here we are with some takeaways at the end of this presentation. Thank you for sticking with me. There are very many similarities between these two vaccines, and like I said, they are functionally the same for me, and very few minor differences between the Pfizer and Moderna vaccines. And they're more logistical than they are about how the vaccines work. Potential side effects of the vaccine are mostly mild and injection site related and or are self-resolving. Again, if you have the opportunity to have a light day after your second dose, your body will thank you. However, with a little bit of over-the-counter medication for some symptom relief, most symptoms resolve quite quickly. Getting vaccine is a contribution to herd immunity, and we only reach herd immunity if we're all in this together. So remember, it's not only for us, it's for everyone else. This is the light at the end of our tunnel. This is our most successful chance of really having a downtrend in the number of cases. Science continues to work on treatment, and they're getting better and better every day, but there is nothing that research has shown to be as effective as vaccine right now, and these two vaccines available are incredibly effective. And vaccines are being distributed in a phased system, so please continue to check online about your eligibility. Am I eligible? New York COVID-19 vaccination, to continue to keep updated as those eligibility groups change and are dynamic. And so keep as informed as you can. And if you ever have questions, reach out to your primary care or COVID hotlines in your community. So some upcoming events, be on a lookout on our website for some pre-recorded COVID educational sessions that are relating to COVID-19 and mental health and substance abuse from local experts and community members. So that is the website on the bottom. Keep it in your bookmark so you can keep looking at it. And other live recorded events are already on that site. And here we are with references to everything that I spoke to today. Thank you so much again for being here and sticking with me. Vaccine is something I'm really excited about, and I've been super grateful and appreciative to get to be a part of this process and watch a community come together to protect itself and protect others and do what we can do to help end a pandemic.
Thank you so much, Kylie. That was incredibly informative, and we have quite a few questions as expected. So we have questions that came in through the chat, and also before this presentation, we sent out a community survey just to better understand what our community is interested in hearing about COVID and what questions they have. And no surprise, a lot of those questions were on vaccination. So I'll be asking you a combination of questions that were submitted through the chat and also that were submitted through that survey. So to start off, a question that a lot of people have probably heard about in the news is how effective are these vaccines specifically against the new South African and the other variants?
So from what I'm most familiar with, relatively up-to-date research is the UK variant, the South Africa variant. Actually, the mutations themselves cause a variation not directly related to that spike protein. So as long as that thumbprint spike protein stays the same in these variant mutations, this vaccine should continue to be effective. The one that was of higher concern was that Brazilian variant, which might have included at least partially the spike protein and a variant in that form. The last press release that I saw was that both Pfizer and Moderna, or Pfizer or Moderna, still saw an effective minimal level of antibody protection of neutralizing antibodies against that variant. It was a decreased total number of antibodies that would have been capable of killing off that variant. However, it still met the minimum threshold that the study had decided is what you need to protect yourself. So overall, the current mutations that we're aware of, both of these vaccines should have some degree of protection. However, it's just one more reason why we need to continue to wear masks. And as we get to herd immunity and to protection against our wild type or the non-variants, we'll have a better idea of how to improve treatments and also potentially boosted vaccines for the future variants to come.
And a follow-up question that was just submitted in the chat that's related. Do you know how we're testing for the new variants?
So it's actually quite difficult because our PCR tests are going to see all of these viruses as the same. The genetic stretch that we look for when we're doing the nasal swabs is going to be something that is unlikely to be a variant. So all of these viruses, variant or not, will likely be something we would test positive for. To know if it's the variant, you need pretty high-tech genetic sequencing labs, which we have in the United States. It's quite expensive, and overall, knowing how many particular individuals have a variant is sometimes less effective than just knowing the variant is present. So we kind of hear it popping up. You might have heard Saratoga may have had a single case of the variant. Well, if it's there, it's probably there in more than one person. And knowing geographic areas where a variant might be can help target public health and research to go to that area to look at that, the way that the virus is acting. And that's where we're really seeing a lot of kind of tells is the variant has clinical ramifications. So maybe it's more virulent, you're more likely to be contagious. So you may see hotspots where populations or entire families are getting ill, where once maybe only one or two members of a household might get it. So those clinical differences are what helps key in researchers and public health and researchers to variants maybe being present. And then from there, they may go off and do genetic testing. But otherwise, we are still moving forward with what we have as our options for vaccination and treatment, and just kind of building our knowledge about these variants.
Perfect. So will there be a vaccination set forth for children, specifically focused at school-age children? And when might that be?
So I have to assume yes. And I have to assume that both Pfizer and Moderna and the other kind of University of Oxford, Janssen, Johnson & Johnson, AstraZeneca, all have those demographics in mind. There is a much higher threshold for safety when it comes to anything for children. So there's going to need to be enough data in adults from the safety standpoint before they can begin to enroll children and minors into that cohort. So is it on the horizon? Yes. Is it on the near horizon? Probably not. But the way we get to that is by getting as many adults vaccinated so we can have the most number of data points to talk about safety in all ages, getting as many 16-year-olds vaccinated with Pfizer and young adults vaccinated with both Pfizer and Moderna is how we're going to meet those standards before we can start addressing what vaccine trials are going to look like in children.
And also related to children, how will the vaccinations impact younger children and their ability to reproduce in the future?
So again, I generally have very little concern. The horror stories about vaccines past and things like long-term consequences, which we think about fertility or chronic conditions, was largely related to preservatives or what we say inert products within the vaccine. So it's really not what makes your body produce an antibody response. It's what makes it be a liquid at room temperature and keeps it viable for a syringe and in the right viscosity. Those inert components are what you often hear are the causative agents for long-term complications. Both of these vaccines have no preservatives. There's no food product, no egg, no animal product at all. The only non-elemental salt really is that polyethylene glycol, which is a common medication we give to children. Children can go on Miralax, they can go on some of these other laxatives where we see polyethylene glycol and polysorbate. So That's an indirect marker for me. It's a medication we already give children, and that's the only other component in this vaccine outside of sugar, some lipid cholesterol molecules, um, which makes me think there should be very little risk for children in the future. And our reproductive systems are kind of ours from birth, and so in knowing that it has not shown any harm in adults, we have very little concern for those who are younger or at any stage of puberty.
Great, thank you. I did want to point out, we have some time left to continue to answer questions, but we have a link on the screen that we've actually set up a Google form where if there are any questions that you think of after or that we just don't have time to get to, feel free to use that form to submit your questions, add your contact information so we have a way of getting back to you, and we'll try our best to get back to you with answers to your questions. So the next question I have for you is submitted through our survey. A lot of people I talk to are concerned with getting the vaccine because there isn't a lot of longitudinal data due to its newness. They want to wait and see if anything happens to the first round of people who get it. I have heard statements that are reminiscent of anti-vaxxer arguments. Do you have any suggestions on how to speak with people like this and help them understand the importance and safety of the vaccine?
That is an ever-going conversation for vaccines in general. But what I think is a really kind of profound argument is the known versus the unknown and which is more dangerous. And right now, I can say with absolute confidence, what we know is that COVID is an incredibly dangerous viral infection for an array of demographics and has caused such great morbidity and mortality in such a short amount of time. That's a known for me. I know the risk of COVID and that it's severe. And it's not only for me, it's for my loved ones and for my community members. The argument of the unknown is you're not wrong. There's not a ton of data, relatively speaking, in this short amount of time. But the data I have looks great. And the data I have through science that I feel trusted in looking at this, this is backed by providers. This is backed by healthcare workers that when the EUA came out, everyone rushed to read it and said, this was good science. This had a really large study population. And the data there is really good and the safety data is good. And so understanding that I can't know everything and I can't know what's going to happen because of the vaccine in a month or 2 months, I do know the risk of COVID. And I feel exorbitantly confident that the risk of being exposed to COVID or what could happen from COVID exceeds my risk for the vaccine. And that's what we have to ask ourselves about anything is which is more of a risk for me? And that's a personal kind of decision. But what I do is share the real dangers and horrors that I know about COVID to be true, and say those just really exceed my concerns about the risk of the unknown. It's a hard conversation, but I think the data is really good and it speaks for itself. And we have done, this mass vaccination beginning sometime in mid-December in 1A across the country to now. If there was any kind of deviation from what the research had shown prior, we would know. We're in month 2, month 3 of this, and we would see patterns across the country that we would be hearing about. And it's just not there because what we're doing is tracking along with the research data, which is really, really reassuring.
I think that you addressed this a little bit, but I thought it was a good question and probably something on other people's minds as well. Someone says, I had COVID in June and almost died. I became a long hauler and I'm still not back to normal. I'm nervous about receiving the vaccine. When will studies be done on how safe these are for those who had COVID and are still recovering months later?
Great question. I am sorry that you are still struggling. And that is one of those realities of COVID that doesn't kind of have a face as much as it should, and is a really good reason to continue to talk about vaccination. Both Pfizer and Moderna included individuals who had COVID as part of their study. And that's how they can say confidently that you can have had COVID and also get vaccine. And not only that you can, you should. So what happens generally for long haulers is that the virus is no longer in your system, but what we kind of say is the damage is done. The virus came into your body. It caused an immune response and an inflammatory response, which we know is really what causes people to be the most unwell when they're hospitalized or need a ventilator to assist with breathing. It's typically related to an overabundance of an immune response that's causing the body to really struggle. And that can cause some chronic damage, that can cause some scarring within the lungs, which can lead to need for oxygen that wasn't otherwise needed, for a decreased level of tolerance to physical activity. And it's not because you're holding on to too many antibodies or you're holding on to too much virus. It's that it was very taxing to your body and it left behind damage. And so I would say to anybody who is a long hauler and is kind of weeks to months out from COVID and still having symptoms, that, keep working at it. It's a marathon, but it's absolutely the reason that you should get vaccinated, because you don't want to get COVID again. And that's really something we know can happen. There is reinfection that is prevalent, that we see in our community, in our county, and across the country. So the safety data actually is theirs for those who had COVID to be able to get vaccine. And I think it's just incredibly important that having severe COVID once is plenty, and not wanting to get reinfected and potentially having an even more severe response to it.
Okay, this question, I know people who are in the North Country have probably realized that a lot of students are coming back to the 4 local universities that we have. So how high in priority are college students when it comes to getting the vaccine?
Interesting. I thought about that myself. I will be honest, I do not know how college students are going to be defined. I think there's kind of a couple arguments going out there, and New York State has not put a kind of finite definition to it. I think there's also going to be some subgroups within college age students, those who live on dorms versus those who don't, and kind of helping risk stratify that. But there has been no specific guidance yet for college age students for when they return to university.
Will the vaccine be given annually like the flu shot?
So part of this being EUA and showing the need to be in community members before longevity trials are finished is that we're seeing in real time those studies progress and how antibodies are maintaining in the system. So right now, neither Pfizer nor Moderna has committed or even really hinted at what that kind of vaccine schedule will look like. They are saying that at this point, they're having really good results on maintained antibodies. So at this point in the studies where, maybe we're looking at like 6 to 8 months max out from those first people who got vaccine, are still having very high level antibodies. So I can make a guess that it's probably not going to be annual. But I could also make a guess that we may need things like booster shots, like some of our other like pneumococcal shots. In a certain number of years, we may need to get another dose. In the media, they are talking generally about potentially a booster type dose if there is any that's targeted towards a variant. So if we see a variant population or a mutation rise in a given area, that this mRNA technology is, once it's kind of the template is started, it's easy to mix and match to help target those kind of new thumbprints. So if there's a new variant where the current vaccine that everyone's getting may not be as effective, it would be a much shorter time to use the same safety process of creating that synthetic molecule, just with different proteins that would help your body create a different type of antibody, could be given. So we may see boosters, not necessarily time interval based, but based on any mutations that the virus may have in even just certain geographic areas.
Next question. I've heard the vaccine does not prevent you from getting COVID, but keeps you from having symptoms. What is the true story? If getting vaccine is not going to stop people from getting it, is it worth getting a vaccine that the producer doesn't need to be responsible for?
Good question. So, kind of multifactorial. One, the first and foremost purpose of the vaccine when it comes out in an emergency use scenario is to one, reduce disease severity. So there is a huge reason that even if we did get COVID, but we all had asymptomatic COVID, people don't die from asymptomatic COVID. That's a generalization. I'm sure that has happened. However, we know the more severe the disease, the more likely your mortality rate increases. So by reducing disease severity, that's actually a huge component to offloading, the weight on the healthcare system, and overall decreasing a mortality rate, which is huge in and of itself. Both Pfizer and Moderna have seen a protective nature from acquisition, but we also need to help kind of better define what becoming infected means. Likely every single person who's on this call with us has been exposed to some degree or another, and those viral particles may have been in or around your face, your eyes, but unless they're able to replicate and become infectious, which is where they're using your cells to replicate and become symptomatic, are you really infected? If your body kills them off before you know you have an infection, and you can't even test positive for them, were you infected? It's kind of what the vaccine does for you. It's not going to stop your body from being exposed, because your exposure is based on your behaviors. So you may become exposed to it. That virus may be in and around your mouth, eyes, and nose, but your body will be primed and ready to kill off all the virus before it's able to replicate and make you unwell. So that's why vaccine's important to me. It is true that you can come in contact with the virus and it may hang out on your surfaces and kind of in your airways like it otherwise would, but it won't last very long. And that's why it's overall protective on the individual level. It really does help prevent acquisition of infection, the risk for transmission, because it's still hanging around in there, and that you can share that much more readily to somebody who may not be vaccinated or have immunity. That's kind of that risk more for the transmission than really having a risk of acquisition.
Great. So we are a little bit past 2:15. Kylie, if you're available and those who are still sticking around, we can still ask a couple more questions. But for those of you who might have to leave, feel free to drop off. You have, again, Kylie just put in the link to the Google form to collect additional questions if we didn't get to your question. So feel free to use that. And please be on the lookout. If you registered for this event, you'll get an email by the end of the day with a follow-up survey as well as a copy of the slides. So I know a few of you have asked for that. So feel free to drop off, but I'll ask 2 or 3 more questions while we have Kylie right here and available if you're able to stick around.
Absolutely.
All right. So will the vaccine affect your ability to donate blood or plasma?
Good question. And I don't have a specific answer. But I would say if you are a donor and you do routine donating, blood donation is incredibly important. And I would refer you to whoever you donate blood with, probably the Red Cross. I also know that there are still Red Cross sites that are accepting blood donations for convalescent plasma, which would be those protective antibodies. So my guess is that it doesn't preclude you overall. They may want you to have a specific duration from when you get vaccinated to when you donate, but I would have you reach out to the Red Cross before going and scheduling one of your blood donations. But I am hopeful that it doesn't preclude people. Blood is tested for so many different things, and it may not be used for traditional kind of red blood cell exchange, but it may be used for protective antibodies for COVID.
One question that we got from a participant, he says, I still don't understand, if I am naturally immune to the virus, why would I need the vaccine? Why wouldn't I want to naturally develop the antibodies?
Great question. So the vaccine's job is to build one type of antibody, and it's a type of antibody that had been studied and proven to be a neutralizing antibodies. Not all antibodies that we make protect us. Some are kind of just like dummy cells that may recognize an infection, but its job isn't to go ahead and kill off that foreign invader. Vaccine antibodies, that is their one and only job, is recognize and destroy. And so we know that the antibodies that the body makes from vaccine are one, infinitely higher in abundance. More will be made by your body because the number of recipes we put in there are going to, directly relate to how many antibodies that we make. And we know that those antibodies are effective. Viruses have many different components. So there's more to a virus than just the spike protein. There's internal components, there's external protein components. And when you have a natural infection, your body is going to make as many different types of antibodies against all of the different pieces of that virus. Now, some of those antibodies might not protect you at all. So maybe the antibody you make for the internal component really is just a waste of a cell and is not going to help you in the future if you're exposed to COVID again. Where we know the antibodies we make towards those spike proteins are going to help neutralize that viral infection. But what's different from person to person with natural immunity is what your body makes is in whatever proportion it wants to do it. So one person may make a whole lot of spike protein antibodies, one person may make a whole lot of core antibodies. And what we don't know is which are protective and to what degree you have each type of antibodies. When we do those lab tests to see, do you have antibodies? They're called total antibodies. It's just how many can you count that appear to be COVID antibodies. So the idea of a natural response, I also don't love that we call natural immunity when it's from an infection. When we vaccinate, it is a natural response. We're only using our own body cells to create that response. So it's not an unnatural way to do this. It's just with a little help. And so your body is going to make, we could choose to make ones that we know will be neutralizing, or with natural infection, they will be kind of an array of maybe some that work and maybe some that don't, and how long they survive. Those cells, those antibodies have varying lifespans. And so some individuals will continue to have antibodies for months and months and months, and others only for a couple weeks. And so what we want to make sure is that everyone has longevity of that antibody protection. So natural immunity, we just can't guarantee how long they'll be there for. And what we have seen is the less symptoms you have, likely the lower antibody response your body will make. And so because the severity spectrum is so big, what we want to do is really make that a uniform amount of antibodies with vaccine. So they're not necessarily better, they're just more targeted, and we know that they work.
Okay, and there are plenty more questions, but for the sake of time, this will be my last question that I ask you live. So are we included in herd immunity if we are vaccinated?
Absolutely. So herd immunity is looking at a population that has protection. And so on a given day, those with natural antibodies are part of that herd immunity. But if their antibodies go away, they fall out of the herd. Just as much as if our vaccinated antibodies were to wane over time, we would fall out of the herd. So if it were, a schedule of every 5 years and I didn't get my 5-year booster, I'm now no longer contributing to that herd immunity. So it's really, do you have some level of protection at this moment in time? And we really want that to be all moments in time. And so we want everyone to stay on a good vaccine schedule, and we want everyone to continue to maintain part of that herd, because we want as many people to be a poor host for this virus. We want as many bodies to be inhospitable to holding on to COVID, that it has no choice but to, die off with good hand hygiene and good hygiene in our homes and cleaning surfaces. So yes, if you get vaccinated, you will be a part of the herd of protection.
Great. All right. Thank you so much, Kylie. I know that I personally, some things were confirmed that I had thought I knew, and I learned new things. So I hope that everyone else thought it was as valuable as I did, just sitting in and listening. So again, please continue to submit your questions and we'll try our very best to get back to you with an answer rather quickly. And please fill out that survey for feedback, because we do read every single response and we want to continue to improve and to continue to offer valuable information to the community. And Kylie, I mean, thank you again. I know how busy you are. You're involved in treating COVID cases here in the St. Lawrence Health System. You're heavily involved in the vaccination effort, and you're doing your other full-time job that you've had before COVID even existed. So I really appreciate your time and you just boiling down all this information into a really nice way for all of us to understand. So
thank you so much for having me. And I think this is part of the solution. I think any kind of treatment or solution without education and conversation really won't get off the ground. So please share anything that you think you've learned today or have confirmed with you, because the more people who know, the better off we'll all be. So thank you for having me, and I really enjoyed that.
All right, great. Thank you all. I appreciate you taking your time to come. Have a great day.